Welcome back to another episode of Reading Rehab. I am Mike Brown, joined by,
Brian Gardner.
And Pat Healy.
and we have another article for you. This time it is Judgment and Decision Making in Clinical and Return to Sports Decision Making, a Narrative Review by Young et al., published in Sports Medicine in May of 2024. So relatively hot off the press.
Dude, May 22nd, 2024. You know who was born on that? Me. My birthday. Man.
That's your birthday.
I didn't even realize
there.
that until right when you brought that up. That's crazy. Oh my God. I love this article now.
That's funny.
Well, I think this article is very interesting because it's looking at a return to play not just on a criterion basis, but also like how do you make those decisions? I think we kind of like look past this on what are you doing and how are you doing it are two different things. I think it's like how do you kind of say this person's good? Like, I mean, in the end, it comes down to like you determining even just the best treatment plan. Like, how do you determine that for this injured athlete? Or say, and this could be just all sports returning to play. Like, say you're a coach just deciding whether or not this player is just returning into the lineup, let alone do you feel that they're ready or prepared. So again, this process is very complex and it's also multifaceted, but I think we're going to try to break it down during this sort of discussion just to kind of give you what that, and at the end, like they do give some strategies that we'll kind of go through too. So
yeah, for sure. And like for specifics on like they define decision making as a cognitive process about selecting a course of action or a choice among alternatives. So like you have to have alternatives to make a decision, and then there are consequences like to each choice being made, like especially thinking return to sport, like to tie into our Achilles article, like you can make the decision to return to sport, but there's a consequence of like if they're truly not ready, or if you feel like maybe they're on the verge and you still let them return to sport, then there could be an increased risk of re-rupture, and that's on you. But yeah, then let's see. One other thing I like that they talk about is like they go into the history of decision making, and really all you got to know is Daniel Kahneman in Tversky. I don't know if I'm pronouncing that guy's last name right, and I can't remember what his first name is. I think it's Alan. But those two are like the godfathers of decision making, and that's where Daniel Kahneman's book Thinking Fast and Slow is super important. And honestly, I would recommend reading that book. And that book gives you everything that this article has, but just more digestible. This article is nice that it's more specific for PT practice, but that's nice to relate to all aspects of your life.
Yeah. And I know we wanted to go over a term that they have in here. There's a whole table of terms here, but one that comes up a lot is heuristics. And this is termed as mental shortcuts or rules of thumb that individuals use to simplify the decision-making process. And then further, the decision is based on a subset of all available information. And then there's different heuristics that they go into. So you have like anchoring, availability, representativeness. Yeah. And then there's simple heuristics that they go even further into that. But I guess like first clinical thought is when I was reading this and saw what they define heuristics as, my first mental thought was thinking about like CPGs and like our TBC treatment-based classification, where it's like do this, respond this way. All right, you're in this category. You're going to do this treatment. And it's like, correct me if I'm wrong, but that seems like a heuristic. It's something to reduce the complex nature of something by giving you simpler judgment operations and decisions.
Yeah. Yeah, it's definitely a good framework for that too.
I think that's
and I
more.
guess
Well, go ahead.
no, you go. I was gonna
I mean,
pivot slightly.
that's kind of looking at the representativeness heuristic or the representative bias, which is pretty much like your likelihood of an object or event belonging in a specific class or process. So that's, again, just going back to even just like what is it, the McKenzie method of like extension versus flexion. Like someone fits within that. It just simplifies it instead of kind of making a complex thing like all over the place. So again, like you said, it is one of those heuristics that they talk about as representativeness. And their example, I think it's like a patient with classic symptoms of a well-known or frequently occurring condition. This just allows you to kind of quick recognition and diagnosis. And their example is a heart attack, someone with signs and symptoms such as chest pain, shortness of breath. Like you're going to have an intervention pretty promptly if that's something that is something present in sort of your case. But yeah.
I think like going into some especially personal examples for each of these things can be pretty helpful. I think I'm sometimes swayed by the anchoring heuristic sometimes. Like I can think of one patient definitely pops into my head where he was an older gentleman with like hip pain, and because he was older and had hip pain, I was immediately like, oh, he's probably got some OA. And that was like mentioned to me by someone I was working with too. Like all they heard was that. And as I was going to the eval, they were like, yeah, it's probably OA. Like give him, these exercises. And so I was going in thinking OA. So that was like my anchored initial thought, which then after probably too long of a time, I finally updated like after some treatments, and he wasn't really responding well. And I was like, oh shit, like this isn't OA.
Well, you're probably running into that other heuristic that they list, availability. It's just a mental shortcut. It's just where it comes more readily available just with what you're thinking.
Exactly. And like the tests that I did were to help rule in OA. Looking back, I wasn't necessarily looking to rule out OA either or rule out other conditions. It was so like I was ruling in OA, but a lot of the OA hip tests are also positive for like other conditions too. So like I wasn't doing a good job of like, I guess, truly diagnosing. I was just confirming my bias of what it already was.
You opened the door and you didn't shut it. You opened it up to everything else to come in and did not shut it to get that specific.
So that's where like anchoring and even in availability bias or heuristics, where availability is like we rely on the most readily available information that comes to mind, like that's where it can lead you astray.
Yeah, but I think it also comes down to like experience, and also like being a new clinician, like you get taught so many different ways to try to help simplify. Because I feel like when you first come out, like you're doing every special test, you're doing all this stuff, and it's like what you're kind of then building is your sort of database of like clinical presentations and that kind of stuff. So you are building your own heuristic, almost like a cognitive biased type of thing, where it's like, oh, I feel this is here and this is here. And so your thought was OA initially because of this test, and this test. Okay, it's OA, but then what did you rule out kind of thing? So I think that's just a normal progression through any sort of clinician. It's like, and it's also that whole saying when you think it's zebras, it's probably just horses. I don't even know. I don't remember that whole saying, but like it's not always zebras that are running around. So, but yeah,
Yeah.
I think it's just building yourself from like an early career where you have all these sort of like things you just learned and then developing yourself over time. And I think that's where we get into that sort of second sort of decision making process that they talk about, and which I think the book is also about.
Yeah. Yeah, they talk about like system 1 and system 2 thinking, where system 1 is like the fast, quick processes that you need to do. So that's like using these heuristics. And system 2 is really like taking your time to like think about it. That's where the fast and slow part comes from in the book. And that's where the thinking slow is then how you then better think fast, if that makes sense. Like taking the time to like truly think through things and like reflect on what you're learning. That's, I think, honestly, so jumping way ahead in the article, like the strategies and examples for improving decision making, I think a lot of that is reflecting on your process too, and like learning what are the heuristics that you typically use, and like maybe their downfalls, and so then you are better prepared to combat the downfalls of that. Because now after that, that experience that I had, now I'm like purposely trying to like rule out other things, and especially rule out the thing that I think is going on.
Yeah, I think if we're thinking about like system 1 and system 2, and also like this availability heuristic, the situation that students and new grads are in, I feel like hopefully pushes you more towards that system 2, because your availability of information and like experience and all that is just not really there. Like if you've never treated someone who, had an ACL rupture or an Achilles repair or something, it's like you don't have those experiences. So you're kind of pushed into like that system 2 where you have to think about it. And I think, although it can be frustrating as a new grad or as a student, where you might not feel like you know it, like everything, which you should never feel like you know everything. You're always learning. But especially in that time where like you've not seen a case, take that time to like dive into it and really like think about how you're going to go about it and how you're going to treat. And, as Mike said, really think slow with that system 2, instead of just jumping to the easiest thing you could probably do in the situation,
Yeah, and then you said the word easy, because obviously being intuitive is super easy and it's cognitively like very fast, and you once you've had the reps and the experience in doing stuff, things become a little bit more clear. So system 2 will take up a little bit more cognitive availability in the beginning, but the whole point is to then allow you to translate into that system 1 as you get enough of those repetitions. So it's like they kind of use like the continuum type of thing, where it's like where you could like start in system 2, but then it kind of slowly gets into system 1 just because you've seen it very frequently. But then also, like Mike was saying, is don't just rely on that system 1, because something can bite you in like that might not be what you're thinking. So it's again being reflective of like, oh, should I have had that person do that high speed running with a hamstring strain? Were they ready? But again, that's again part of this conversation is about like, when do you make that decision on when they're ready?
Yeah. And like thinking about how you're saying like the shift of it all, I know Mike brought up anchoring heuristic for his situation, but I think anchoring can also be a good idea, like not a good idea, but it can also be represented in your thought process of like intervention or evaluation. Because if it's just, decision makers are anchored on the initial values and later update their perception with better info. So if you're starting, in the like system 2 heavy cognitive load, and you're trying to implement what's like the best research of the time for whatever case you're doing for eval or intervention, and then it's like, okay, that research is probably relevant for a good amount of years, but like you just get better at doing it, so you turn to like that system 1, but then it's like 10 years rolls around and it's like, well, things might have changed for that, but you're still in that system 1, and it's like, all right, maybe time to find your way out from that quick intuitiveness that might have been the best thing 10 years ago, but now what's it say now? What's the information nowadays on that, and bring us back, and like kind of like that wave pattern that you were talking about, Brian, where you're kind of going back and forth, because then it's like finding the best way to treat people the most efficiently, but then also trying to figure out what's the best way for yourself to learn and get better, so you can treat those people in the best way.
Yeah, I think that gets to something that, like, I think that's what the best clinicians do. Given like still consider myself a new grad, only a year out, so like I guess I can't say I've had the available experience to do this, but like in my opinion, and the small experience that I have had, like I think the best clinicians are the ones that, okay, they do have this quick system 1 thinking from years of experience doing this, but then they purposefully go back into that system 2 to potentially question their thinking, or revise their system 1 thinking, so then they're continuing to get better, not just like living in the same thought processes. What were you gonna say, Brian?
No, I was getting ahead of myself with like a strategy that I use is have a group of friends that are willing to challenge you, because I think that's where, well, why did you do this? Well, then it makes you think, or have a mentor or mentors that kind of you can bounce ideas off. Oh, what do you think with this? Like, I was thinking this. Like, it just allows you to kind of just speak what you're thinking, and then have someone almost like be a check, or like something that could be like, did I really mean to do this, or was I doing it this way? Like, would I have done it differently? So like, yes, still use that intuitiveness, but like also be able to like, oh, what do you think about this? And use your network to kind of help improve your skill set, and reflect in that way. I also think it's context driven, because obviously, working on pitch, things and injuries happen relatively pretty quick. So having that intuitiveness is like vital in some sort of situations. I can't just sit there and be like, man, this guy's leg's broken. Now what do I do? And so it's again, I think it's also context driven. When you have the time to kind of sit there and kind of use your head to kind of develop what this person's dealing with and how to go about it, you should. But I also think if you're crunched for time, I think it has to be like that, and then be able to reflect off of that and ask people like, this is what I did. Like, is that right? Because like sometimes you are dealing with life and death, like depending upon what the situation is. Not saying every injury is life and death, but there are some crucial sort of injuries that will happen, especially in sport, that you got to make critical decisions relatively quick. You can't think about it. But knowing that you've had training to kind of help with that, I think is where that sort of system 2 should help with that system 1. So it's almost like they support each other. It's just being able to kind of know that sort of timing of when to use what.
Yeah, I'm glad you brought that up, because that was exactly what I was going to say. It's just like get a group of people that can challenge you and like challenge you on your thought process. Because the article brought up the idea of blind spot bias, where it's basically just saying like humans tend to think that we are smarter and less susceptible to cognitive bias than others. And it's like, no, we actually all have bias, and we might exude confidence in our own decision making, but does that mean it's like the right one? Well, that's not really easy for us to figure out. Sometimes you do need other people to like step in and challenge you, because if it's, if it ain't broke, don't fix it. But come to find out, it might be broken. You just don't know it.
Yeah.
Sometimes
It's broke, but you don't know.
Yeah, sometimes
Yeah,
you can just be blinded by your own sort of, I don't want to say ego, but just by your own sort of vision of like you said, if I could be doing something that is I view as the right thing, but it might not be.
and also I think in PT, I mean, this is definitely going away from the article and getting like more philosophical and maybe controversial, but like in PT, we might think we're doing a great job because our patients are getting better, but our patients might be getting better just because of like time, which is where then you have to think about natural history and all these other causes for like why are they getting better, because we might be doing a shit job on rehab, but maybe they're getting better because they really like us and they're really bought into what they're doing, even if what they're doing is not truly beneficial. And to tie what we're talking about to the article too is like they give in table 3 strategies and examples for improving decision making. I've already mentioned that before, but like a lot of what we've been talking about is in this. So group decision strategies, seek others' opinions and apply crowd wisdom. Consider alternatives. You can do that by yourself. You can do that with multiple people. I know in the clinic I'm currently in, we have clinical meetings every week to just like go over potentially tough cases, like kind of do this same process. And my boss really enjoys playing devil's advocate. So like, okay, I think it's this thing going on. And he's like, so what if it's not? What if it's this? And I'm like, but it is, I swear. So, so like that sort of thing. And that's where it goes into like supportive environment too. So those are 3 of their 6 strategies, all like wrapped into one, like mentorship, uh, relying on your network. In this network and mentors, they don't need to be in person. Obviously, it's nice to have that, but as when I was working as a travel PT, I had my fiance, which was great because then she's also a PT, and we could both like talk to each other about our like potentially difficult cases and do these things. But I mean, we were both new grads, so maybe we didn't have that experience. We didn't know what we didn't know. So I leveraged, my network of people that I could call or text or something, and that was super useful too. So just because you might not have people immediately available to help you with these things, that doesn't mean they aren't out there, I guess.
Mm-hmm.
Are you guys good if I pivot a little on that conversation?
Pivot.
Yeah.
Give me, stick pivot, man.
Yeah. So then we've been mostly talking about like their heuristic and bias section 2, but then section 3 has simple heuristics too, which are just smaller, like easy things to think about. Like there's the confirmation heuristic, like we look for things that support our hypotheses and don't try and they say falsify the hypothesis. So that's what I was doing with my hip OA patient. But then also thinking specifically about like what do I use or like think about a lot in clinic is their last one, the framing effect. The different phrasing ways, that's weird how they phrased that, can change a neutral message to an implicit recommendation and affects one decision, such as treatment selections. So like not necessarily with treatment selections, but one way I think about this a lot is, so we do an exercise with a patient and then I ask them, did that feel good? How did that feel? That's like, did that feel good? Did that feel bad? Versus what are you feeling? Like the good or bad frames it so like they should feel one way or the other and that they just agree with you.
Also, when it is a patient ever said when you asked if it felt good, did they say no?
Yeah. Yeah.
So you're almost
I've
like,
had it a couple times, but when we're doing exercises, not with like me pushing on them.
it's because you're also just like, you're changing their frame of mind. Like, I'm in pain. So it could be some of that sort of psychological aspect of it, but it's like, yeah, you're just framing it to the way that you may want to say, oh, does this feel really good? And I've had very few times where they're like, nope, that feels terrible.
Yeah, exactly. Yeah.
But
Yeah. Or like even starting with like if it's some manual thing, like saying this should feel really good, like that frames it like, oh, this is going to be really beneficial for me. Um, I think framing is something all PTs do all the time, and it's really easy to like get caught in that loop. And so it's really easy not to check yourself with how you're framing questions.
Just gaslighting our patients. This feels good, right?
yeah, and
Yeah.
then I also think PTs use a lot of, they have a 3.2, that elimination by aspects. It's pretty
Mhm.
much reduces alternative by eliminating those that don't meet required sort of criteria for specific attributes, meaning that, like, that's what you were talking about, the ruling out side of things. It's like you make a differential and it's like, okay, I'm going to eliminate these and this, and then it will eventually get to that. So like, that's not saying that this heuristic, we're not saying heuristics are bad. They're just a way that we kind of help with making decisions. And that's just one of them that, I mean, quite frankly, I use relatively quite frequently in my own practice. It's like, okay, because like you're not going to use every special test under the sun, because one, it just takes too long. And two, it's like, come up with like your 3 big rocks and then rule them all out. And if you're at the end of the third one, ruled that one out, obviously, then you got to go back to the drawing board. But like, I think that's an easier way, especially as a new clinician, to kind of like look at it and say, okay, I got hip pain. OA is 1. Some sort of lumbar is 2, like something else, whatever. And so like, then you can go, okay, ruled in this. Did I rule this out or did I not? Did I rule it out? Then good. I'll take that one off the board, and then you'll eventually come to whatever your hypothesis is. So again, we're not saying heuristics are. It's all about like taking that and not just being blinded and just your bias take over, like that confirmation bias, because that is where I think you can become a little bit blinded to like your sort of things where you can grow in. Because if you think you're always right, it's not. Sometimes you are missing out on some other things that you could be work-ons, if that makes sense.
For sure. Yeah, it's like heuristics are a tool that we use. Like they're not inherently good or bad. It's how we use the tool. Like a wrench is a wrench. You're not going to try and put a nail in the wall with a wrench, probably.
But you can.
Yeah, and that's the thing too. I think maybe that's a perfect analogy for the heuristics. Like you can hammer a wrench into or hammer a nail into the wall with a wrench if you're really trying. But yeah, do you guys have any other thoughts on this article? I feel like we hit most of the big parts.
No, that was it.
Yeah.
No,
Cool.
I'm good.
Well,
yeah.
All right. So this has been another episode of Reading Rehab. As always, if you enjoy what you hear, please leave a nice rating on Spotify, Apple Podcasts, however you listen, and follow us on Instagram at Reading Rehab Pod. Thanks.